So it's just get the second link. So the heart failure and cardiomyopathy. Okay, so heart failure is, we call it as a syndrome, or it is a complex clinical syndrome that results from either structural or functional cardiac disorder that impair the ability of the ventricle to fill in heart failure with preserved ejection fraction, or eject blood as in heart failure with reduced ejection fraction. So before we call the heart failure either systolic or diastolic, but now we change the name to heart failure with reduced ejection fraction or heart failure with preserved ejection fraction. When the ejection fraction less than 40, we'll call it heart failure with reduced. When it's more than 50, we'll call it preserved. When it's between, we'll call it heart failure with moderate reduction of ejection fraction. So this is the normal heart. So you can see the left ventricle, the right ventricle, right atrium, left atrium. This is the aorta, and this is the pulmonary trunk. In systolic heart failure or heart failure with reduced ejection fraction, you can see the heart muscle is weakened, so less blood will be squeezed to the body. So it will result in heart failure with reduced ejection fraction because of the weakened muscle and dilated left ventricle. In heart failure with preserved ejection fraction, you can see the thickness here is more, so less blood will be in the left ventricle, so less blood will be ejected to the body through the aorta. So this is the pathophysiology of heart failure with reduced and preserved ejection fraction. So we have two classification systems for heart failure. We have the NIHA class or NIHA functional class, the New York Heart Association functional class, and we have the ACC-AHA stages. It is the American College of Cardiology, American Heart Association stages. The functional class, when there is no limitation of physical activity, we'll call it class 1. If it's class 2, when the patient has slight limitation of physical activity. When there is a marked limitation, class 3, and class 4 when the patient has dyspnea at rest. And the stages of heart failure, stage A, B, C, and D. A, when there is no structural heart disease, but there is a risk factor for heart failure. B, when there is a structural heart disease, but there is still no heart failure symptoms. C, when there is a structural heart disease with prior or current heart failure symptoms. And D, when the patient has refractory heart failure requiring frequent intervention like medication or coronary angiogram. The majority of the causes of heart failure is due to coronary artery disease. So 70% of the cases. And the other major causes for heart failure is hypertension and valvular heart disease like aortic stenosis and mitral regurgitation. Less common, myocarditis, tachyarrhythmia, hypertrophic cardiomyopathy, stress-induced, cocaine, chemotherapy, obstructive sleep apnea, rheumatological disease, infiltrative diseases like hemochromatosis, amyloidosis, and some chronic diseases like diabetes, HIV, and thyroid disease. Hypo or hyperthyroidism can cause heart failure. So symptoms, dyspnea and orthopnea, which constitute 90% sensitivity and specificity for a heart failure patient. Some people, they might have syncope, especially when they have arrhythmia, swelling or dependent edema, fatigue and weight gain from the fluid overload. Some patients, they might have anorexia and abdominal pain, especially from right-sided heart failure. In physical exam, you might see respiratory distress. The patient will be tachypneic, and you will listen to respiratory crackles. In cardiac exam, the patient might come with brady or tachyarrhythmia, displaced pulse of maximal impulse, jugular venous distension, S3, gallop rhythm. Abdomen, you might see ascites, hepatomegaly. Extremity will be cool, dependent edema, cyanosis, or pallor. In the ECG, you have to check for either the patient might have ischemic heart disease. So ischemic heart disease is one of the cause of heart failure, or you might look for other diagnoses because sometimes you might see LVH, arrhythmia, or some feature of pulmonary embolism. In chest X-ray, you might see pulmonary venous congestion, cardiomegaly, or pleural effusion. In the lab, you have to order CBC, comprehensive metabolic panel, troponin, thyroid function test, because you have to exclude or to know what is the cause of heart failure. Echo to evaluate the severity, cause, and characterization of heart failure, either reduced or reserved ejection fraction. And in the setting of acute coronary syndrome, you might order the coronary angiogram to see if there is any blockage or any stenosis. And some patient, you might order cardiac MRI and right heart study. BNP, yes.
معذرة for السي بي سي بتكون helpful بإيش يعني؟
If the patient has anemia, so that's one of the precipitating factors for heart failure. It is number one precipitating factor for heart failure. And also chronic anemia, it will cause heart failure. So it is causing and it is precipitating for heart failure.
يعطيك العافية.
الله يعافيك.
دكتور؟
Yes.
في بايوماركر معين يعطينا انديكيشن على الهارت فيلير، يعني زي كان وي ريلاي اون الان بي ولا التروبونين اكثر ولا كلهم ايكوال؟
BNP is more for congestive heart failure, troponin more with the ischemic heart disease. Okay, so BNP or pro-BNP, they are equally have good sensitive and specific in diagnosing congestive heart failure. When the BNP less than 100, the congestive heart failure will be unlikely. When it's more than 400, the most likely it is congestive heart failure. But just bear in your mind, the BNP, it might give you false positive, especially with age, renal disease, sepsis, coronary artery disease, women, patient, African-American people. And it might give you a false positive in obese patient. So in acute heart failure, it is a predictor of mortality and cardiovascular events when the level is more than 200. So in the management of heart failure, we have acute heart failure management and we have chronic management. So in acute heart failure management, we have to maximize the oxygenation. We have to give the patient oxygen or non-invasive ventilation or invasive ventilation, vasodilator like nitrate, diuretics like loop diuretics, inotropic support, either dobutamine or mirlinone, ultrafiltration, which means fluid removal of the body, because some patient you can't give them diuretics because of kidney impairment, and some people you might use a temporary mechanical circulatory support. That's for the acute management. In chronic management, we have to have a lifestyle modification for those patients, and we have to manage their chronic medical management like hypertension, diabetes, dyslipidemia, or thyroid disease. And those patients should be vaccinated, pneumococcal, flu vaccine, and COVID vaccine, low sodium diet, alcohol, tobacco cessation. Some medication, they have to be avoided by those patients. And we'll come to medication that reduce the mortality, like ACE inhibitor or ARB, beta blocker, aldosterone antagonist, hydralazine plus isosorbide dinitrate. Also, we have the sacubitril valsartan, we call it ARNI, and SGLT2 inhibitor for mortality reduction in patients with heart failure. So ACE inhibitor reduce the mortality and hospitalization based on randomized clinical trials. We have to start all patients with heart failure on ACE inhibitor regardless of their New York Heart Association class. Beta blocker, it is also proven in randomized trials that it reduced the mortality And morbidity, we have a lot of beta blockers, but the most studied beta blocker in heart failure is the metoprolol, bisoprolol, and carvedilol. So any patient with heart failure, they should be on beta blocker, except if the patient is hypotensive, and if the heart rate is less than 60, if the patient had AV block, or patient has severe peripheral artery disease with ischemia. Aldosterone receptor antagonist, will give it only to the patient with, also it reduces the morbidity and mortality. We'll give it to the patient with New York Heart Association class 2 to 4 and LV ejection fraction less than 35%. We have to monitor the kidney function and potassium. So that's for the aldosterone receptor antagonist. Hydralazine isosorbide, it also reduces the morbidity and mortality. We'll give it to the patient once they have optimized ACE and beta blocker. And it is more beneficial in African American people with New York Heart Association class 3 to 4. Digoxin, it is only improve the morbidity but not mortality. Diuretics only improve the symptoms, and anticoagulation, we will give it only if the patient has other indication to give the anticoagulation, like atrial fibrillation, pulmonary embolism, or deep venous thrombosis. Fish oil, it is conflicting evidence for this to give it to the patient with heart failure. Statin, there is no evidence to give it in patient with heart failure, except if the patient has dyslipidemia. And calcium channel blocker, we have the dihydropyridine and non-dihydropyridine. The dihydropyridine, we can give it safely in heart failure people, but the non-dihydropyridine group, like diltiazem or verapamil, it is contraindicated in heart failure patient. So the two recently approved novel drugs, the ARNI, the sacubitril valsartan inhibitor, it is also proven in randomized clinical trial to reduce the cardiovascular death or first heart failure hospitalization. And the second one, yes.
معلش عندي سؤال. النون هيدروبيريدين contraindication in general ولا in addition to مثلا beta blocker?
No, in heart failure patient, you can't give them. Any patient with reduced ejection fraction, the diltiazem or verapamil, it will increase mortality. So it is contraindicated. But you can give them the dihydropyridine like amlodipine or philodipine. Okay. So there is two recently approved novel drugs to treat the heart failure. It is very evolving medications, and it is reducing the morbidity and mortality. The first one is ARNI, and the second one is the SGLT2 inhibitor, which reduce the cardiovascular death, hospitalization for patients with heart failure with reduced ejection fraction, and now recently with preserved ejection fraction. So this is about medication, and now we'll come to devices. We have the ICD, or the implantable cardioverter defibrillator, and we have the cardiac resynchronization therapy. We call it the RCT, and the ICD. So ICD, we use it in primary prevention if the patient has prior MI more than 40 days and ejection fraction less than 30%. Will give them, or will put ICD to prevent death, because low AF in ischemic cardiomyopathy, those patients are prone to death because of arrhythmia. If the patient has NIHA class 2 and ejection fraction less than 35%, if the patient have been on maximal medical therapy for 3 months and still the ejection fraction is less than 30, you have to give them ICD. And if there is any syncope with structural heart disease and sustained VT or VF on AP study. So those patients are eligible for implantable cardioverter defibrillator. And that's for the ICD. For the CRT, or the cardiac resynchronization therapy, We have grade 1A indication, we have grade 1B indication. This is very important. So if the patient has a sinus rhythm, QRS complex more than 150 millisecond, now the new guideline 120 to 150 millisecond. Or when the patient has a left bundle branch block and ejection fraction less than 35%, with New York Heart Association more than 3, with optimal medical therapy. So it is important. It is important that patient will be on optimal medical therapy. If the patient fulfill this criteria, they are eligible for cardiac resynchronization therapy, and that will improve the morbidity and mortality for those patients. For grade 1B indication, it is almost the same. Sinus rhythm, QRS complex 120 to 150 millisecond, left bundle ejection fraction less than 30, NIHA class of 2 with ICD placement. So you will just upgrade the ICD to the CRT, because ICD has two, one in the LV and one in the left atrium, one in the RV and one in the right atrium. But for the CRT, you will have one lead to the left ventricle. So this is, we call it upgrade ICD to the CRT. We'll just add one lead to the heart.
دكتور
Yes.
هذول هم يعني كلهم بيس ميكر يعتبرون جهازين؟
No, pacemaker is used only for heart block, but this is ICD, so this is implantable cardioverter defibrillator. It will give the patient defibrillation when he goes into VT or VF, and it will work as a pacemaker also if the heart rate is going down, but it is not like it is a pacemaker. Because pacemaker doesn't have defibrillator, so it won't give shock. Those devices will give shock.
حتى الريسynchronization كلهم نفس الفكرة يعني.
Yes, so it is the cardiac resynchronization. It is like ICD, but with the third lead in the left ventricle. Because the ICD, there is two lead, one in the right atrium, one in the right atrium, one in the right ventricle. But for the CRT, there is one more lead to the LV. So it will resynchronize the left and right ventricle at the same time. So the symptom will improve and mortality will improve. So as I said at the start of this lecture, so the heart failure is a syndrome, or it is a complex syndrome. So we have to have a multidisciplinary approach, patient education, instruction. We have to have appropriate hospital follow-up 7 days after discharge. We have to manage the comorbidities like diabetes, hypertension, ischemic heart disease, dyslipidemia, or thyroid disease. And all these decrease the hospitalization and improve the quality of life. Moderate exercise in chronic stable heart failure decrease the mortality by 25%, and it improves hospitalization and quality of life. So here's the new European Society of Cardiology guidelines for treating the patient with heart failure. So they will start ACE, ARB or ARNI first, and then beta blockers or at the same time, and SGLT2 inhibitor. And if the ejection fraction less than 35%, they will add the MRA or aldosterone antagonist. And if the patient has a volume overload, you will give them diuretics. And if the patient has a left bundle branch block, you might consider the device therapy, CRT D or P. And if the patient has atrial fibrillation or aortic stenosis, you will treat those medical problems individually. Here, the algorithm to diagnose the heart failure. So this is the European guidelines. If you suspect the patient has heart failure, you will order the BNP. If the BNP is high, the heart failure is suspected, then you will order the echocardiogram. And then depends on the echo, you will decide this patient has heart failure with reduced ejection fraction, moderate ejection fraction, or preserved ejection fraction. Then we have to determine the etiology and commence the treatment for those patients.
دكتور
Yes.
الحين الجولد ستاندرد to diagnose heart failure ايكو يعني هل هو الايكو ولا
So echo is the gold standard to diagnose the heart failure, but this is the algorithm for diagnosing the heart failure patient. Because in Europe, not everyone will come to the clinic or to the hospital, they will get the echo. The waiting list for them is 2 to 3 years. So they will just get BNP. If the BNP is normal, heart failure is less likely. If the patient has high BNP, they will organize the echo maybe in 6 months or less than 6 months.
طب دكتور بالنسبة للتريتمنت اللي قبل شوي السلايد اللي قبلها الحين في خطوات أمشي عليها مثلا في البداية أعطي ايس أو ارب وبعدين
So AS, ARB, or ARNI, so 3, because ARNI is the same mechanism of AS and ARB.
يعني نختار يا الايس أو الARNI مع البي بي
plus beta blocker. And now, because there is a lot of studies supporting the SGLT2 inhibitor, I use the SGLT2 inhibitor. So for my patient now, I'm starting either AS, ARNI, or ARB, depends on the patient criteria, plus beta blocker, either metoprolol, bisoprolol, or carvedilol. Plus, I will start the SGLT2 inhibitor. This is at the start. Okay, and then if the and then I will. If he still has some symptom and ejection fraction less than 35, I will consider adding the MRA. Okay.
اللي هو aldosterone antagonist.
اللي هو aldosterone antagonist. And if the patient had volume overload at that time, you should give them diuretics.
يعني الانيشال تريتمنت تعتبر الدكتور الايس او الARNI مع البيتا بلوكر، هذا كانيشال تريتمنت.
Plus SGLT2 inhibitor. I start my patient now on that medication also.
Okay.
Okay, so here the management of patient with heart failure with reduced ejection fraction, AS, ARNI, or ARB, beta blocker, the DAPA and IMPA, this is the SGLT2 inhibitor, and loop diuretic for fluid retention. And then according to the ejection fraction, you will decide, and all those criteria I give it to you, you will decide about the ICD or CRT. Here, there is some possible approach. So let me see. So this is the conventional approach. But now I think there is a lot of changes. Even this is in 2021 in Circulation. This is one of the best medical journal for best medical or best cardiology journal, the Circulation. But I will go with this one. I will go with ARNI, SGLT2 inhibitor, beta blocker, and then step 3 MRA. Not this one, because there is a lot of evolution now in study about the SGLT2 inhibitor. So I will just go with this one. I will even put this one plus ARNI, ACE, ARNI, or ARB, plus beta blocker, plus SGLT2 inhibitor, and then step 3 MRA.
دكتور معلش بس SGLT2 هذه ما كانت حقت diabetes anti-diabetic.
أول شيء that's the SGLT2 inhibitor. It was for or proved to be for diabetic patient. It reduced the hemoglobin A1C. When they did that study, they discovered that there is subgroup analysis. They saw that there is a cardiovascular morbidity and mortality for those patients for those subgroup analysis. They did more clinical trials, and they found the SGLT2 inhibitor improve the cardiovascular income or outcome for the heart failure, and now for all cardiovascular. And now there is like a study 1 or 2 months ago. It also a kidney protective. So it is a cardiovascular morbidity and mortality benefit. It has also kidney protection, and it is used for a diabetic patient. But I use it if even the patient is diabetic or non-diabetic. I have to use the SGLT2 inhibitor because study proven that it is improving the morbidity and mortality in those patients. So now the SGLT2 inhibitor, the cardiologists use it more than endocrinologists. Okay, so here I think also I will add this one here. So ASR or ARNI, SGLT2 beta blocker and SGLT2 inhibitor. And then assess the and then you will go for individualization therapy. If the heart rate, you will check other thing if the patient is black, or if the patient has atrial fibrillation. You will just tailor your therapy based on individualization therapy, and then you will titrate or recheck in 1 month. If the patient is stable on that, you will see him in every 3 months. Okay, I think we finish here the heart failure, and then we'll move to the cardiomyopathy.
دكتور كان في سؤال
Okay, so do we put the patient at risk of arrhythmia by using MRA? No, it won't cause arrhythmia, the MRA. It is improving the morbidity and mortality, but it won't cause arrhythmia. I didn't hear any things about arrhythmia caused by MRA.
دكتور
Yes.
كان في سؤال في السلايد أقصد ما
Which
ودك
one?
نناقشه قبل شوي انت فتحته بس عديته يعني.
Do you want the, because I didn't see any interest from your group, so this is why I just left it.
دكتور من اليوم نتكلم معك يعني ودنا
بالعكس دكتور.
نتناقش فيه.
Yeah, because no. I'm just keen on you. أنا ممكن أجي أعطيكم المحاضرة في نص ساعة وأمشي، وممكن ما أعصب ولا تعب نفسي. But هذه أمانة علمية يسمونها، لأن أنا حريص عليكم.
صحيح.
I want your interest. I want you to ask, to think. This is not exam. You should ask. أنتم يعني you are not expert, and I'm not expecting you at resident level, or you are only student. يعني ما راح أهاوش أحد أقول لا والله ليش ما سويت كذا.
أبدا دكتور الأخطاء واردة يعني والتقصير وارد.
No, if there is no interest, I will just give the lecture.
لا والله بالعكس. والله بالعكس.
Not the other thing. Okay, so if you want the question, we can go with the question.
اي والله ودنا ان نتناقش فيها على اساس يعني نشوف كيف الفهم.
دكتور بس سؤال قبل أن نتناقش.
اوكي.
بخصوص الMRI أنا سألت إنه هل يسوي أريثميا ولا لا، لأنه سبير البوتاسيوم، فقلت ما أدري أسأل يعني.
No, because I just put in the slide, you have to check the electrolytes. You shouldn't give it to a patient with high potassium 5, no, more than 5. Okay, so I'm tired from reading, so maybe anyone.
مو مشكلة اقرأنا يا دكتور.
Okay, yeah, just go.
A 74-year-old man is evaluated in the emergency department for a 7-day history of progressive exertional dyspnea associated with a dry cough, increasing orthopnea from 2 to 4 pillows, and inability to buckle his belt. He has a 20-year history of hypertension. On physical exam, blood pressure is 162/86. Pulse rate is irregular at 84 per minute. And respiration rate is 18 per minute. Estimated central venous pressure is 14 centimeter. Cardiac examination reveals an irregular rhythm and an S4. Basilar crackles are heard on auscultation of the lungs. His liver is enlarged 2 centimeter below the costal margin. His extremity examination reveals bilateral pitting edema. Serum electrolyte levels and kidney function tests are normal. Serum B-type natriuretic peptide level is 2,472. ECG shows atrial fibrillation. Echo shows a left ventricular ejection fraction of 60%, septal wall thickness of 1.5 centimeter, and posterior wall thickness of 1.4 centimeter. Chest radiograph shows hazy bilateral infiltrates. Which one of the following is the most appropriate next step in management?
Okay, what do you think, Faisal?
Beta blocker, cardioversion, furosemide, spironolactone. I think furosemide.
Why furosemide?
Because we said that we can't use in this case the beta blocker.
Why you can't use it?
Because it will he having heart failure and it will exacerbate the heart failure.
Okay, so beta blocker is contraindicated in acute heart
Yes.
failure. Excellent. So why it's not cardioversion?
He's not having an arrhythmia, so no
So
point.
he
of
has-
Yeah,
using
the heart rate is controlled.
Okay, so he has
And,
AFib, but it is controlled, so no need
Yes.
for cardioversion.
Furosemide, we will
spironolactone.
use it because he have edema.
And why is not spironolactone?
Spironolactone is aldosterone antagonist, so
It has no effect on the heart, يعني دكتور.
yes.
It has.
So-
It's
Okay, so first here, this is acute heart failure management. Okay, so you will maximize the oxygenation. You will give diuretics because this patient obviously came with exertional dyspnea, progressive orthopnea, and PND, and his BMP is 2,400. And the chest X-ray also showed bilateral infiltrate, or because it is look like pulmonary edema. So this the best management here is the loop diuretics is the furosemide. Beta blocker is contraindicated in acute heart failure patient. Cardioversion, because the patient had ECG, but the heart rate is controlled. I think the heart rate, what is the heart rate? Heart rate is 84, so it is controlled, so you don't have to give the cardioversion. Spironolactone, ejection fraction here is 60, and spironolactone is used in chronic heart failure management, but not in acute heart failure management. So you have, so this is acute or chronic. So this is acute. You have to go to algorithm of acute heart failure management. Regarding the diagnosis here, so the ejection fraction is 60%. So this is heart failure with preserved ejection fraction, not reduced ejection fraction. But the septal wall thickness is 1.5 centimeter, and the posterior wall thickness is 1.4. The normal wall thickness of the heart is less than 1.1 centimeter. So this is fit the criteria of heart failure with preserved ejection fraction, because in the second or third slide, I just show you the thickness of the left ventricle in patient with heart failure with preserved ejection fraction, because there will be less blood coming to the left ventricle, less blood will go to the body. So this is why we call it heart failure with preserved ejection fraction, because there is a wall thickness, either septal or posterior wall thickness. So this is acute heart failure management. The answer is furosemide. Okay, excellent. Okay, question 2. We'll read it and try to answer.
Can I read?
Yes, you can go ahead.
A 56-year-old man with heart failure is admitted to the hospital with a 2-week history of increasing exertion, dyspnea, and fatigue. He has also type 2 diabetes mellitus. Medications are metformin, lisinopril, carvedilol, furosemide, metazoline, and digoxin. On physical examination, the blood pressure is 88/60 mmHg, the pulse rate is 95 beats per minute, and the respiration rate is 20 per minute. He is somewhat confused and inattentive. Jugular venous distension is present to the angle of the jaw while sitting. Cardiac examination reveals an S3. There are bibasilar crackles on pulmonary examination. He has edema to the mid-thighs. Extremities appear metalled and are cool to the touch. Serum creatinine level is 3.1 milligram DL. Baseline value was 1.1 mg DL. Serum sodium level is 133 MEq L. ECG shows no evidence of ischemia. The chest radiograph shows cardiomegaly and vascular congestion. In addition to intravenous diuresis, which of the following is the most appropriate management?
Okay. So what do you think here? Or what is the scenario first? Like general, what
General,
is it like acute, chronic, or what's happening here?
It's a chronic case.
Chronic, yeah, chronic, because he has
Chronic with
type 2
acute
diabetes.
exacerbation, maybe.
Okay, so the patient has chronic, but now he is coming with acute. So it is acute because he is admitted to the hospital with 2 weeks exertional dyspnea. Okay.
طيب.
What other points that is very important here?
The jugular venous distension is present to the angle of the jaw.
Hypotensive.
So he has high JVP and hypotensive. This is important, one of the most important points.
And
He has a risk factor, diabetes mellitus.
Yes, diabetes mellitus as well. Type 2, which is a chronic disease.
Okay, what's your answer here? What do you think?
دكتور عندها acute kidney injury.
Okay, yes, creatinine level of
Creatinine level is 3.1, yes.
It has edema.
Okay, so what is the management for this patient?
A.
Milrinone, maybe.
Dopamine A.
Milrinone. Why? Who said Milrinone?
أنا عبد الله.
Okay, Abdullah. Why Milrinone? I like this medication, Milrinone, in treating heart failure patient. But why you said Milrinone?
I just know that it's used for decompensated heart failure. and its positive inotropic action has a positive inotropic action.
Okay, so excellent. It is one if, but I won't use it if the patient has serum creatinine level of 3.1. So it is contraindicated in acute kidney injury. If there is no acute kidney injury, I would use mirlinone here. So mirlinone is out because of kidney problem. So you have to know the side effect of medications or the contraindication. So mirlinone is out because of kidney problem, because creatinine is 3.1, so you can't use it.
اي يا دكتور.
اي دكتور.
Okay.
اي دوبتامين.
A دوبيتامين. Why دوبيتامين؟
لان الباقي اصلا احنا قلنا الميرلينون كونترانديكيتد في الاي كي اي، والبي والدي كلها انفيزيف، تعتبر انفيزيف مانجمنت، انتراورتيك بالون بامب والرايت هارت catheterization. So we want to go to invasive management before we're trying with dobutamine.
بالاضافه دكتور ان السيجز هذه تعتبر سيرجيكال يعني انترفنشن، فهذه ما تكون الا اذا خلاص يعني كل الطرق الثانيه ما بعد، فهذه نستخدمها. لو كل الطرق الثانيه ما فادت يعني، فهذه تعتبر اخر شيء نسويه اللي هي السيرجيكال بروسيجرز.
Okay, good. So we have two options here. We have either dobutamine or mirlinone, because patient is heart failure and hypotensive, so you have to give him some inotropic support. So mirlinone is out because of acute kidney injury, so we left with dobutamine. If the dobutamine is still patient hypotensive, you might go with the intra-aortic balloon pump or right heart study to see is this heart failure or the answer here is dobutamine. What other points here in this question that I might give you some point? Okay, that's good. Okay, question 3. We'll read it and we'll think about the answer. We'll read question 3.
Can I read it, Doctor?
Yes, you can. Go ahead.
A 66-year-old woman is evaluated for prior to discharge. She has ischemic cardiomyopathy and was admitted to the hospital 5 days ago for worsening symptoms of heart failure. She skipped taking her diuretics during a recent business trip. So today, she feels well and is able to walk around the ward twice without any symptoms. This was her first hospitalization in 3 years. Although she has skipped her diuretics during other business trips without apparent ill effect, she had an implantable cardioverter defibrillator placed 3 years ago. An echocardiogram 1 month ago showed a left ventricular ejection fraction of 15%, stable for the past 6 years. Medications are captopril, metoprolol, succinate, digoxin, furosemide, and spironolactone. On physical examination, blood pressure is 110/72 mmHg. The pulse rate is 56 beats per minute, and respiration rate is 14 beats per minute. She has no jugular venous distension and no S3. Lungs are clear, and she has no edema. ECG shows sinus rhythm, a QRS interval of 90 milliseconds, and Q waves in V1 through V4. There are no changes compared to the admission ECG recorded three years ago. Which of the following is the most appropriate management? So this is a patient who has ischemic cardiomyopathy, and she was taking diuretics, but she skipped taking them. She had placed an implantable cardioverter defibrillator 3 years ago, and there is an echocardiogram done to her, which shows a left ventricular ejection fraction of 15%. and she's taking some medications like captopril, metoprolol succinate, digoxin, furosemide, and spironolactone.
Okay, so what do you think here?
We put her back on her diuretics and we wait.
So
Should
what is the answer?
A.
A.
Discharge and schedule follow-up within 7 days.
So why is not measurement of BNP?
She's not having new symptoms. Everything is normal, within normal range, except for the blood pressure and the pulse, which can be in the borderline. Otherwise, she is normal, I believe. So no need to remeasure it.
Okay, why it's not echo?
She's
Also,
walking.
Because
she's walking.
and echo is costly.
She
it
had
is-
an echo 1 month ago and having 15 ejection fraction, 15%, and it's stable for 6 years. So no need to
Okay.
repeat it without symptoms.
Okay, so there is no need because it's 1 month ago and that was stable. Okay, why it is not D?
Because she had it.
She had an implant, the cardio verter defibrillator.
Okay,
She is not, Victor. She's having
Okay.
she's having normal sinus rhythm. So
Okay.
no need to put her on biventricular defibrillator.
Also, there is no LBBP.
Okay, there is no left bundle branch block and the QRS complex interval is less than 120 or 120. It's not 120 to 150. So it is 90 milliseconds. So it is not an indication to upgrade this ICD to biventricular implantable or biventricular ICD. Biventricular ICD is the same as CRT. Okay. Because as I mentioned, the ICD has 2 leads, one in the RA and one in the RV. When we upgrade it to CRT, it has 3 leads. So it will be one in the RA, one in RV, and one in LV. We'll call it biventricular. So it is the same name as CRT, either biventricular ICD or CRT. Okay, so the answer here is A. So you will discharge and just reschedule her for follow-up for 7 days because she doesn't have symptoms. No need to measure the BNP. Echo is recently and it was stable, and there is no points or there is no indication to upgrade her from ICD to CRT. Okay, excellent. We'll come to question 4. Anyone?
Okay.
اقرا دكتور.
Yes, any of you?
فيصل تقرا.
لا عادي اقرا انت.
77-year-old man with a 5-year history of idiopathic cardiomyopathy is evaluated for progressive exertional fatigue and dyspnea. He has recently stopped carrying groceries from the car because of his exertional dyspnea. He had an implantable cardio-verter defibrillator placed 3 years ago. Medical history is also significant for hypertension. Medication are lisinopril 40 mg per deciliter, metoprolol succinate of 25 mg, furosemide 40 mg, and spironolactone 25 mg. On physical examination, blood pressure is 94/60 mm per mercury and pulse rate is 70 per minute. Estimated central venous pressure is 5 centimeter. There is no edema. Serum electrolyte levels and kidney function are normal. ECG shows normal sinus rhythm. A PR interval of 210 millisecond, QRS duration of 160 millisecond, and the new left bundle branch block. His left ventricular ejection fraction 3 months ago was 25%. Which one of the following is the most appropriate next step in management?
Okay.
دكتور هذه عكس الحالة اللي قبل شوي صح؟ يعني تقريبا عكسها، لأن نفس الإمبلانت حاطين لها والنيو هنا في الكيس هذه إن عندها ليفت بندل برانش بلوك.
Okay.
النيو ليفت بندل برانش بلوك.
اتوقع جوابي
what?
اعتقد دي يا دكتور، لانه ليفت باندل برانش بلوك فليفت ventricular assist device placement.
No, so the left ventricular assist device placement, this is different from cardiac resynchronization therapy.
The answer is A, because it is a grade 1B indication for CRT.
Okay,
The
excellent.
patient is having prolonged QRS and left bundle branch.
This patient has ejection fraction less than 30%, 35. QRS complex more than 160, left bundle branch block, and still symptomatic. And she is, or he is, on maximum tolerated medical therapy, because you can't add any medication because blood pressure is on the borderline 94/60. The vitamin therapy, I won't call it because this is borderline. It's not hypotensive. So the vitamin is not indicated here. Increase furosemide. Because the patient on furosemide 40 and blood pressure, if you give more furosemide, his blood pressure will drop. So the CRT will improve his symptoms. So there is an indication to put CRT. So the answer here is A. Okay, this is question 5. Who will read it?
Okay, a 72-year-old woman is evaluated for progressive heart failure symptoms. She has 10-year history of non-ischemic heart failure. She currently experiences exertional dyspnea with the clamping one flight of stairs, which she was able to do without shortness of breath 3 months ago. Medical history is significant for hypertension, and her medication are lisinopril, carvedilol, furosemide, digoxin, and spironolactone. The patient is black. On physical examination, blood pressure is 134 per 72, and pulse rate is 66 per minute. BMI is 30. She has no jugular venous distension. Cardiac examination reveals a grade 1/6 holosystolic murmur, but is otherwise normal. There is no lower extremity edema. The remainder of her examination is unremarkable. Laboratory studies are significant for normal electrolyte levels and a serum creatinine level of 1.5. ECG shows normal sinus rhythm, a QRS duration of 110 ms, and non-specific ST wave change. Echocardiogram shows a left ventricular ejection fraction of 38% and trace mitral regurgitation. Which of the following is the most appropriate treatment?
Okay, so what do you think? Okay, take it one by one and then see.
Okay, added hydrolysine and isosorbide dinitrate.
Okay, now you will just consider which you will just exclude, and then you will come. Maybe you will left with 2 or 1. So is a possible answer here or not?
لا, البي added losartan. I will exclude it because she's taking lisinopril.
Okay, so you can't put patient on ACE or ARB together. So
Yes.
B is out.
A is the answer, Doctor.
Okay, let's go with warfarin. So what do you think with warfarin?
Warfarin. I will not use warfarin
Why?
because the ECG shows normal sinus rhythm.
Okay, sinus rhythm, there is no indication to start warfarin. So there is no, so warfarin, you will use it only if the patient has atrial fibrillation, pulmonary embolism, or DVT, or if the patient had mitral valve replacement, and there is nothing in the history suggestive of that. So B and C is out. D.
Cardiac resynchronization therapy will exclude it also because there is no left bundle branch block, and the QRS is duration of 110. Also, the ejection fraction 38%.
Okay, so there is no indication for.
So the only
D.
answer is A.
So the answer is A.
Ventilator.
Okay, so this is how to. So there is some tips and tricks in answering the question. I usually go first to the answer quickly, just to see what he want, what is the answer is concentrating on. So he's concentrating here on management. Okay, so when you read the question, you will just concentrate on management, because if you just look, this is my like tips and tricks in solving MCQ. I'll just go quickly to the answer, just quick skimming, and then I will just go to the question quickly. 72 progressive heart failure. You will see lisinopril. You will just exclude losartan directly when you are reading the question. You will just, okay, losartan is out, digoxin, spironolactone. You'll see here ECG sinus rhythm. So, okay, warfarin is out. And when you are reading QRS complex 110, ejection fraction 38, no left bundle. Okay, D is out. So you will just put A directly. So this is how to answer the MCQ questions. Just go to the answer quickly. Just look at the answer, what he want, and then just go to the question, and then you will answer correctly.
طب دكتور عندي سؤال معلش.
Yes.
أسئلتنا في الاختبار راح تكون زي كذا ولا هذا ليفل يعتبر يعني عالي؟
No, it is not like this. This is like brainstorming, not question. But you will have some cases. You will have some cases. Not like what is the heart failure management and ACE Harvard, no, because you are now in fourth year medical school, so you should have some clinical scenarios. Okay, so we finished with heart failure. We will give 2 minutes, and then we'll come back for cardiomyopathy. Okay. Assalamu alaikum. Okay, we'll just, I think cardiomyopathy won't take 10 to 15 minutes. It's not like ischemic heart disease or heart failure. So it is from the name. So cardiomyopathy, myo is from the muscle. So it is a disorder of the heart muscle or any myocardial disease. So this is simply the definition of cardiomyopathy. So we have different classification. You might see different than this classification. There is dilated cardiomyopathy, there is hypertrophic cardiomyopathy, restrictive, arrhythmogenic right ventricular hypertrophy, which is very rare, and we have unclassified cardiomyopathy. We don't know which class we should put it under. So this is the pathophysiology or some physiology of the, so this is physiology and this is pathophysiology. So this is the normal heart. So this is left ventricle, left atrium, and this is the aortic valve and aorta. So this is the normal. So you can see the thickness is normal. So the thickness of the left ventricle should be less than 1.1. In dilated cardiomyopathy, you can see here, it is from the name, dilated. So the left ventricle is dilated, so the muscle will be weak. We'll call it dilated cardiomyopathy because the left ventricle is dilated. In hypertrophic cardiomyopathy, you can see here, the left ventricle is not dilated, but you can see here the thickness of the left ventricle is increased. So it is more than 1.1 centimeter. So this is the hypertrophic cardiomyopathy. So less blood will be in the left ventricle. So less blood will be ejected to the body through the aorta. In the restrictive cardiomyopathy, which is the difficult one, the difficult pathophysiology, the thickness is the same as normal, but there is stiff myocardium. So this is the pathophysiology, stiff myocardium. So the left ventricle, because of the muscle, the myocardium is stiff. So there is less blood will go from the left ventricle to the aorta because of that stiffness. Okay, so is this clear? So dilated cardiomyopathy characterized by ventricular dilatation and impaired contractile performance, which may involve left or right ventricle or both left and right ventricle. So the causes may be idiopathic, so if there is no identifiable cause, or maybe due to prior myocarditis, toxin, infection, chemotherapy, predisposing cardiovascular disease like hypertension or valvular heart disease. We saw now a lot of, or not a lot, but there is some cases post-COVID vaccine and post-COVID infection itself. There is 50 to 60% of such patients have familial disease and causing mutation, which identified in 10 to 20% of such families. So you have to look for familial also, and to the other family if you diagnose one patient with idiopathic dilated cardiomyopathy, because sometimes you can it can be familial. So I won't go with this detail in this dilated cardiomyopathy. So in the other cardiomyopathy is alcoholic. So alcohol and its metabolite like acetaldehyde are chronically or acutely cardiotoxic. It initially caused myocardial depression, reversible. It will be reversible at the start or initially, but if it's sustained, can lead to irreversible cardiomyopathy. The amount of alcohol necessary to produce symptomatic cardiomyopathy in susceptible individual is not known. So it's different from person to person. Abstinence can lead to improvement in at least 50% of patients with severe symptom, some of whom normalized their left ventricular function after the abstinence. Chemotherapy, I think the Saudi Commission for Health Specialists like bringing the trastuzumab, one of the cause of increased incidence of heart failure. So this medication or this chemotherapy used in breast cancer management. So it has been associated with increased incidence of heart failure. Doxorubicin also can cause. Cyclophosphamide and 5-fluorouracil can cause. I saw two cases of 5-fluorouracil causing coronary artery spasm and decreasing the left ventricular contractility.
دكتور يعني causing
yes.
heart disease ولا heart failure?
Those all chemotherapy causing heart failure. Cardiomyopathy and heart failure. So cardiomyopathy, it is muscle disorder. It is, so it will cause heart failure. Some skeletal myopathy like Duchenne muscular dystrophy and Baker X-linked skeletal muscular dystrophy. It will lead, because it is a muscle and the myocardium is a muscle, so it will involve the myocardium of the heart and it will cause cardiomyopathy. Peripartum cardiomyopathy, it is very important. It appears in the last month of pregnancy or in the first 5 months after delivery in the absence of pre-existing cardiac disease. Some people, their ejection fraction might normalize after 6 months in more than 50% of the patients. Hypertrophic cardiomyopathy, this is one of the genetically determined myocardial disease. It is defined as presence of unexplained left ventricular hypertrophy, especially in young population, and pathologically presence of myocyte disarray surrounding and increased area of loose connective tissue. It is usually familial with autosomal dominant inheritance. So you should, if you discover one patient, you have to do whole family screening. Any pattern of thickening may occur because we have a lot of thickening pattern. We have like septal, we have concentric. So any pattern can happen in patient with hypertrophic cardiomyopathy. Hypertrophic cardiomyopathy may be during the first year of life or childhood, but more typically during adolescence, because we are screening those patients in the adolescence age, especially at early 20. Most patients will be asymptomatic or only have mild intermittent symptoms. Sometimes symptomatic, if the patient has a symptom, those symptoms might progress slowly and associated with gradual deterioration in left ventricular function. Symptom may develop at any age, even at many years after appearance of left ventricle. Sometimes sudden cardiac death may be the initial presentation. في لاعب بتوقع السنة الماضية نسيت اسمه عنده hypertrophic cardiomyopathy, he just sudden collapse in the في الدوري الأوروبي أو شيء زي كذا نسيت اسمه. He had hypertrophic cardiomyopathy. Restrictive cardiomyopathy, as I mentioned, there is no dilatation in the LV and no thickness of the left in the muscle of the left ventricle, but there is impaired filling and reduced diastolic volume due to stiffness of the muscle. There is primary and there is secondary cause. Primary form are unknown, and there is some secondary causes. I will come to it now. Restrictive cardiomyopathy may be also familial cause. and you have to screen the family for that. Secondary causes is here, so either infiltrative like amyloidosis, sarcoidosis, storage disorder, fibrotic disorder, metabolic, endomyocardial, and some rare cases like carcinoid syndrome. Pathophysiology, as I mentioned, it has increased stiffness of the endocardium or myocardium, which induce the ventricular pressure to rise disproportionate to a small change in volume until maximum is reached. So it's only stiffness in the myocardium. There is no dilatation and no myocardial thickness. So this is the end of the lecture, and if there is any question, let me know.
يعطيك العافية دكتور، ما قصرت.
الله يعافيكم يا رب إن شاء الله.
درنا على القصور يا دكتور.
اوكي، لا ما في مشكلة. الله يستر عليكم كلكم جميعا وبالتوفيق إن شاء الله.
آمين وياك إن شاء الله.
يلا مع السلامة.
أمان الله.